Hi, I'm David Kolko, and I'm going to give an overview of Alternatives for Families, a Cognitive Behavioral Therapy, or AFCBT. AFCBT is a family-focused intervention that is designed to address the clinical problems associated with exposure to conflict and coercion within the family. We realize that that covers a lot of clinical ground. And so what we want to do is say a little bit about the focus of AFCBT. Generally, we see AFCBT as being mostly appropriate for children ages 5 to 17 and a participating caregiver who show any of these types of problems: anger or defiance and arguing, hostility, verbal or emotional abuse, the use of physical force or discipline, including aggressive behavior, and physical abuse, as would be reported to a child welfare authority. AFCBT targets strengths as well as strains or difficulties by tailoring interventions to the needs of the child, the caregiver, and the family. And I want to explain a couple of these elements. What we mean by strengths and strains, of course, what we mean by strengths is adaptive skills, competencies. And so we focus a lot on teaching new behaviors in addition to trying to help children and caregivers unlearn behaviors that are unwanted or undesirable or problematic. And what we've learned in our field is that it's not simply enough to get rid of unwanted behavior and to try to eliminate problems. It's also important to build in strengths, competencies. The second point I'd like to make is that we try to tailor interventions in our intervention model by focusing on the child or the caregiver, and in some cases, the child and the caregiver together. So in AFCBT, we have content for the child alone, we have content for the caregiver alone, and we have content for the two of them together. Now, AFCBT also addresses what we believe to be some of the risk factors for these types of problems, as well as the clinical consequences of being exposed to those risk factors. And we do so by trying to teach intrapersonal skills as well as interpersonal skills. And I'll explain that for a moment. The risk factors usually involve caregiver or family characteristics that increase the likelihood that a child exposed to aggression or emotional abuse may actually experience his or her own clinical problems. So it's our obligation to look at and try to target those risk factors in order to reduce the likelihood that that child is going to be exposed to those risks, and therefore we can reduce the likelihood that child will show clinical consequences. But of course, for many of these children, they're already exposed. They already show clinical problems. They already have mental health consequences as a result of this exposure. And so our job there is to try to not only reduce, but ultimately eliminate the clinical problems that they're experiencing. Now, the way we try to do this is by focusing on intrapersonal skills and interpersonal skills. Now, what I mean by intrapersonal skills are those skills that we teach that help a child or a caregiver gain some type of cognitive or emotional control over their functions. So, for example, we teach children how to think more adaptively. We teach caregivers how to think more constructively and positively about their children. And the hope, of course, is that by teaching those intrapersonal skills, they're more in control of themselves and they're better able to apply the other skills that we're going to teach them that they would demonstrate to others. And that's the second area, which is interpersonal skill. Once someone has learned intrapersonal skills, they have some composure, they have some emotional regulation, they can think more constructively. The hope is that we can then work with them together and teach them interpersonal skills, which are the skills they're each going to use to influence other people. Now, the content of AFCBT is divided into 3 treatment phases. And those phases are designed to engage the family, to teach skills, and then to promote family routines and safety. So our first phase is called engagement in psychoeducation. The second phase is called individual skill building. And the third phase is called family adaptations. Now this rather overwhelming slide has an acronym, alternatives, which begins at the bottom left and goes up the page to the upper right. And it shows the content associated with each of those three phases in different colors. So the content listed in the first phase, which is engagement in psychoeducation, is in green. And I just want to give a brief explanation of this content as part of this overview. So the first piece of content deals with alliance building. And the point here, of course, is that we recognize that many families may initiate services in AFCBT and they either are not yet committed to AFCBT or motivated to change their behavior. And we recognize that it's important really to ensure that we have a good relationship with them and they with us, and that there is trust and a willingness to work together and a willingness to continue in treatment. The second topic has to do with learning about feelings and family experiences. And this is something we do with the child. And we focus on both positive as well as negative experiences in the home, and then psychoeducation around the role of trauma and exposure to the types of incidents that have occurred in that child's life. We do something very similar with the caregiver, where we talk about family experiences and do psychoeducation as well with the caregiver. And then we move to the next phase, which is the individual skill building phase. And there we have each individual, the child or the caregiver, receiving skills training alone. So we work on emotion regulation first with the caregiver and then the child. We also work on restructuring thoughts, dealing with cognition, thinking, for both the caregiver and the child. We work with the caregiver around noticing positive behavior or positive parenting skills, such as praise and attending. Then we work with the child and we teach assertiveness and social skills to help that child get along and hopefully be reinforced by those positive parenting strategies. We then work with the caregiver to teach techniques for managing behavior, for correcting a child's unwanted or troublesome behavior. And then the final topic in this particular phase deals with imaginal exposure for those children who have high levels of post-traumatic stress or post-traumatic stress disorder, secondary to some experience involving physical discipline or force or physical abuse. And then in the third phase, the family applications phase, we review healthy communication skills training with both of them together. We work on clarifications if that is relevant for the family, especially if this is an important area in a case involving physical abuse, where there might be a lot of emotional distress that needs to be addressed, and a parent is being asked to provide some type of apology and highlight how things are going to be different in the home. And then what we work on is teaching positive, non-aggressive, or non-coercive problem-solving skills, again, with the child and the caregiver together. So that's just a list, briefly, of the primary content or topics in AFCBT. So what are the common clinical features of this population, and especially the characteristics that we're going to target in AFCBT? Here are some of the characteristics that the literature has suggested for children who have been exposed to physical abuse or physical discipline. And what you see in this list are a number of problems and a number of concerns that AFCBT will try to target. So the first has to do with being aggressive or exhibiting behavior problems or some type of antisocial behavior. This is probably the most robust clinical consequence of exposure in the literature. A close second is the idea that many of these children have very limited or poor social skills or social skill repertoires. They're not very socially competent and not very adaptive. And what's important to highlight here is that in the first case, we have too much of an unwanted behavior, But in the second case, we have not enough of a desirable behavior. And this gets back to my point that we sometimes try to reduce deviant or unwanted behavior, but we also try to build in or build up or strengthen wanted, desirable competencies. We also may find trauma-related emotional symptoms such as post-traumatic stress, anxiety, depression. Some of these children experience negative attributions. They see themselves as to blame for the physical abuse or the aggression directed to them. They may have difficulties getting along with peers, getting along with adults, teachers, and then they may experience a broad range of neurophysiologic problems, and this is an area that is also getting a fair amount of attention now. Now, what are we learning about caregivers? And again, this gets at some of the risk factors that children are exposed to. And as you can see, some of these risk factors and characteristics are very similar to, they parallel what we just showed in terms of children. So many of these parents have been aggressive, or they have used pretty harsh methods or punitive methods for disciplining children. They don't seem to rely very often on positive parenting. There are negative child expectations that they may hold, or they may see their children in very negative ways. They may be insensitive to the child's needs and not be very good at discriminating what those needs are. They themselves may have their own mental health problems in terms of heightened anger or sadness. They may experience psychiatric disorders. In some cases, the literature suggests high levels of major depressive disorder and substance abuse disorder. And then finally, there's research showing that caregivers of children who've been physically abused have high levels of physiologic arousal to unpleasant stimuli, such as a baby crying. And I wanted to point out a little bit of the research literature on family characteristics. And what you see here is that families involving physical aggression or that have been involved in physical discipline or abuse often have certain characteristics such as being coercive or having high levels of conflict, meaning there are frequent arguments in the home. They may be socially isolated, which often means they prefer to be alone and insular. They don't often go outside the family for information. They're not very involved in social activities in the community. They may have their own limited psychosocial or financial resources. And they may live in communities where there are other dangerous activities or where there's a perception that the community is unsafe. Now, of course, all of these characteristics make for a challenge when you bring cases like this into treatment. We recognize that these characteristics make treatment challenging and complicated. And it's important to recognize many of the challenges that these families may bring as we see them. And so it's important to ask yourself this question: what are some of the challenges that I face when I work with this population? And so this is a good thing for you to consider as you're undertaking this particular intervention with this particular population. Some of the more typical challenging behaviors that we see that relate to physical abuse or aggression or conflict in general are listed on this slide. And that, they involve a variety of behaviors, some more worrisome perhaps or serious than others, all of which though require special training and procedures in order to manage them. So disinterest in change, someone who may be involved in a session or be coming to treatment who may not be that interested in changing their behavior. They may not be that interested in changing their behavior. They may minimize the degree to which they've been involved in abusive or aggressive, unwanted behavior. They may be fairly dismissive of the need to change, or they may not see what they did as having been problematic. They may challenge your authority or the authority of other health professionals. They may get angry in the session. They may get hostile in the session. They may also show these same reactions, of course, in the community. and they may be threatening and aggressive in the session or again out in the community. So ask yourself this question: how common are these features, these characteristics, and these challenges in the families on my caseload? And give some thought to, in what way are you prepared to handle them? And in what way is your setting, your agency, your program, your practice prepared to address them as successfully as possible?
Hi, my name is Barbara Bauman. I'm an AFCBT trainer and consultant. I'm going to be talking to you today about the theories behind AFCBT. This will help to understand how all the different parts of AFCBT fit together. AFCBT is a combination of several theories: cognitive theory, social learning theory, family systems, developmental victimology, and the psychology of aggression. I'm going to go through each of these one by one to help understand and explain through examples how each one contributes to the model. The first is cognitive theory, and it's probably the best known of them all. Cognitive theory posits that your thoughts are connected to your feelings and actions, and that by changing your thoughts, you can change your thought, your feelings, and your behaviors. Cognitive theory helps us to understand when thoughts are unhelpful and when they are helpful. And our challenge with our clients is to help them to identify the difference. Let me give you an example. You may have two adults watching a child temper tantrum. One adult thinks, "Oh my gosh, when is this going to stop? This is so embarrassing. People are going to think I'm a horrible parent." That parent might get very angry, very anxious, run over to the child, grab them roughly by the arm, and drag them away. The result of this, the consequence, is that they and the child will then get into a big fight perhaps. Perhaps there'll be conflict for the rest of the evening. The parent may feel guilty in the end. The child may still feel distress. And in the end, no one feels better. Another parent watching the same situation may think, "This too shall pass." They walk away a few feet, talk with a friend for a while calmly, and wait for the tantrum to end. When the tantrum ends, the parent feels calm and goes over to the child to talk about what happened that caused them to tantrum in the first place. The consequence or the result is that the parent and child learn to talk through their issues. The child learns self-soothing behavior, and their evening or the rest of their day is pleasant. This is just one example of how cognitive theory affects family interactions, the type of interactions that we focus on with AFCBT. Many clients come into therapy wanting a specific situation or person to change. If only their ex-spouse were better, if only the school had a better principal, if only their child was better behaved, or their boss was more understanding. What we teach them through cognitive theory is that they can change their thoughts. That's what they're in control of. They may not have control over the principal or their boss or sometimes even their child, but they can control how they think about these situations and how they react to these situations. And that's our challenge as clinicians, to help people find those helpful thoughts that are meaningful to them and will help them to make a change. Social learning theory posits that behavior is a result of an interaction between a person and their environment. So children learn to act aggressively through the feedback they get from their environment in terms of reward and encouragement. Children act on their environment, and their environment acts upon them. So if we work with caregivers and others in the child's environment to reduce their level of aggression, that itself can reduce the child's level of aggression. They're each related to the other. We can also work with parents and family members to talk about the meaning of aggression to them that they are transmitting to their child. Are they transmitting the message that they want to about the use of violence and aggression? By helping families find situations in which aggression is not appropriate, children are able to change their beliefs and their behaviors when deciding to use or not to use aggression. Caregivers may not realize that they are teaching or encouraging aggression by the way they react to their children. By working with caregivers, AFCBT is impacting the entire environment. We know that just by working with one individual in a family can only go so far. It's when we work with each member that we have access to that we can help to change the whole family dynamic. For example, if a kid tends to handle problems in coercive, aggressive manner, which the parent either ignores or gives a lot of attention to, then the behavior may continue. Working together with those in the environment to develop new behaviors and to reward these new behaviors will encourage their development. Family systems is a key theory in the AFCBT model. Our model is based around the idea that caregivers and children affect each other, and that we therefore need to work with each of them to make change in the environment and in the aggressive behaviors. Children and parents initially work individually with a clinician, and then as they gain the skills necessary to promote positive relationships, we bring them together for family sessions. These family sessions promote the idea of trying out new modes of communication while using the skills of emotion regulation, thought restructuring, and positive parenting and social skills that they have already learned. Parents and children also work together collaboratively with the clinician to develop problem-solving methods that will work for their family, that will allow them to operate and solve problems when they're not involved with the system, when they're outside of therapy. These are ways we create new connections and interactions within the family. Rather than continuing to repeat the conflictual relationship, we help families find these new paths. Children often take responsibility for what's going on in the home, the good and the bad. Often, if a family is involved in child protection services, the child will take responsibility for that involvement and for the negative consequences that have come after it. We work together with the parent and the child for the parent to begin to take responsibility for their behavior and their actions. We work with the parent separately on what we call a clarification letter, and then bring them together with the child to help them begin to restructure their family system so that the parent is the one taking charge and taking responsibility for what happens in the family. Another consideration when working with children is their developmental stage, and this is where the theory of developmental victimology comes into play. To this end, AFCBT incorporates the child's stage of development in everything that we do. So while you'll receive a session guide that lays out a general format for presenting different types of skills, adapting these skills is just as important, and adapting them to the child's level, their age, and to understanding when the trauma occurred, if there has been a trauma in their life. How did that affect them? And we know that their early upbringing can affect things that happen later in life, and that each stage builds upon the next. So a child with a stable early upbringing may be influenced differently by a later trauma than a child who had a chaotic upbringing. By putting all of this together, we can help to design our treatment so that it fits the child specifically for their age, for their level of aggression, their level of trauma. Whatever it is that they're coming in for, we want to make sure that we tailor the skills and the treatment to be the most helpful to them moving forward. In the theory of developmental psychopathology or developmental victimology, psychopathology develops over time. And if we help to go back through with the child their family experiences, we can help to understand how they came to the behaviors that they currently use. Lastly, we look at the impact of the psychology of aggression on children and caregivers. Aggressive behavior can be influenced by negative emotional states, by modeling that they see around them, and by high levels of distress, such as frustration or annoyance. The person's aggression then leads to reciprocity. Perhaps they're aggressive towards someone, and then someone is aggressive back to them. Aggression can also lead to a reward. It may be that the child wants what another child has, and by aggressively taking it, they get to play with it. It can also lead to control over situation. They can get out of somewhere they don't want to be. They can get to go someplace they want to go, all through the use of aggression. The challenge we have as therapists is to help caregivers and children figure out a better way to get what they want, a better way to get the rewards, the control, and to value a different kind of reciprocity, a kindness for kindness rather than aggression for aggression. Being able to identify when you're beginning to feel the distress is one of the keys we emphasize in AFCBT. If children and adults can identify when they're beginning to get annoyed, irritated, frustrated, then they have a chance to stop, to calm themselves down, to think differently about a situation, to use one of the skills we're helping them with, so that it doesn't escalate into the rage and the anger that so often characterizes their lives. Often this means trying to find something that works for this person in different settings. Perhaps they live in a crowded home environment and they don't have a quiet space where they can take some time to go through deep breathing or relax. Perhaps it's happening to them at school and they don't want to stand out. Perhaps it's in the hallway when another child approaches them aggressively. In AFCBT, we'll work with children through all their different situations, as well as parents, to find what works for them to replace the aggression. We still want them to gain control, and we want them to be able to escape negative situations, but we want them to do so in a way that's positive and socially appropriate. Thinking about the psychology of aggression helps us as clinicians to understand why it sometimes pays to be aggressive and to help our clients find other ways to behave.
I'm Dr. David Kolko, and I'm going to talk a little bit about the research support for AFCBT. The first study actually on AFCBT was done in 1990, even though pilot data were collected in the mid-80s. The most recent study on AFCBT is actually being conducted now, and we're just analyzing some of the data from that trial. So as you can tell, there's been a pretty long history of conducting research on AFCBT. So here is a slide that shows some of the outcomes that we have found with AFCBT, and I'll just go through them a little bit to give you an idea of the support for the model. The first studies that were conducted were with families that were referred for either physical abuse or some type of physical force, physical discipline, or family conflict. And in that study, those individuals who were referred for the study either received cognitive behavioral therapy, they either received family therapy, or they might have been receiving routine community services. And I want to mention that the CBT intervention and the family therapy intervention have now been combined in AFCBT. So at one point in the past, they were studied separately to understand their individual contributions. And then both of them were compared to routine community services. Now that was a small study, 55 individuals. And as a result, we have done other research to confirm or at least extend those findings. And so one of the studies that was done recently is a study done in another state in a child protection center where families were not necessarily randomized to conditions. They received whatever services they were supposed to receive from a clinician. And that clinician had learned one of several evidence-based interventions. It could have been AFCBT, it could have been trauma-focused CBT, it could have been PCIT, or it could have been child-parent psychotherapy, or it actually could have involved all of them. And that study was published in 2011. And then there was a study that was recently done with individuals who were seen by providers. Those providers were randomized to either receive AFCBT training or just routine training in their agency. So this slide puts together the findings from those studies. And what you can see is that there have been reductions reported in the AFCBT condition compared to the other community conditions or the other control conditions, in the level of caregiver aggression that's reported, as well as the amount of verbal and physical aggression that a caregiver has indicated he or she may use with a child in the home. We've also found that the children themselves have reported, and some of their caregivers have reported, that they too have been less likely to use verbal or physical aggression after exposure to AFCBT. Children and their caregivers have also reported on separate scales a reduction in family conflict. So they are saying that they argue or don't get along less often. They also have reported that there are reductions in the perceived level of harm or danger or concerns about safety. And this is important because, of course, we're trying to improve safety and child protection, even though we're also focusing on well-being and kind of clinical functioning or adjustment. And then finally, we have some data from child abuse records, from official records, indicating lower rates of recidivism for those individuals who receive the AFCBT content in comparison to those who have received other interventions. And an example is, in one of the studies, we've reported rates for the CBT that I originally mentioned of 5% and a rate of 6% for the family therapy, whereas the rate of recidivism for the routine community service condition was 30%. So again, a 5 to 6 times lower rate of recidivism in the AFCBT-related conditions. Now, those, of course, are important. We are obviously trying to reduce the likelihood that a child is going to be hurt, that a child lives in danger, that a child is unsafe, that a child is exposed to harsh discipline or aggression or abusive behavior. But, of course, we're also interested in improving the adaptive skills of that child and, of course, the competencies of the caregiver. So what you see at the bottom of the first slide is that we've also demonstrated significant improvements in perceived child safety, in the child's actual self-competence based on an actual social skill assessment measure. We've also reported from the standpoint of the caregivers that they have seen themselves improve in their level of nurturing, their caregiving responsibilities. And also we've seen children and their parents report improvements in how well they get together, their level of cohesion. So what's nice is that we balance reducing problem behaviors with improving strengths, adaptive behaviors. And these are consistent in the studies that have been examined for AFCBT outcome. Now, we've had other research, not directed necessarily to maltreating families, but directed to families of children referred for a behavior problem, perhaps oppositional behavior, aggressive behavior, being unmanageable. And so there are a few trials that have examined AFCBT content in the context of other interventions like medication for ADHD, compared to families who received outside services from another provider. In all likelihood, those outside services did not include any AFCBT. So in these studies, we're really looking at a multi-component intervention that includes, as its foundation, the AFCBT content. And again, as I mentioned, it's not with a maltreating family, it's really with a family coming to a primary care office looking for services for a child with behavior problems. What's also interesting here, if you look at the top part of this slide, is that we also show significant reductions in the problem behaviors that those children were referred for. So, for example, there are reductions in their unwanted problem behaviors, there are reductions in their general problems, there are reductions in their ADHD symptoms, there are also reductions in a caregiver reported anxiety and depression. And the caregivers also were asked to complete a measure that gets at their own parental stress. And sure enough, they report lower levels of parental stress after exposure to AFCBT than to some outside intervention. So that's a good thing. We're showing kind of improvements in unwanted problem behaviors, but we also can see at the bottom of the slide that there are improvements in the child's general treatment response. So the children are doing much better, they're more functional, less impaired. The families who receive the special content that includes AFCBT show higher levels of satisfaction with their services. And even the pediatricians in those offices where the AFCBT content was delivered report more satisfaction with the services and the outcomes of their own patients. So this is a nice demonstration of multiple outcomes across different informants, all showing some benefit for the AFCBT intervention relative to other interventions. Now this is a slide from the original study I mentioned, so it's fairly old, and what it shows is the probability that the families in this intervention trial remained force-free based on weekly reports of the use of force from the parent, the caregiver, or the child. I'm showing you here just the parent data. I'll show you in a moment the child data. So let me explain the graph. Every family that comes in, regardless of their history, is considered force-free from the start of the study because they haven't used any force. Once we start asking questions in the first session, the second session, and all subsequent sessions, when a parent reports that he or she has used physical force, then this graph begins to drop because that case is no longer force-free. So they are no longer force-free, they've actually used force. And by the way, the force could be any kind of physical aggression. It isn't necessarily something that's going to hurt the child. It could even be just routine physical discipline like a slap or a spank. But what you see is that the parents report almost from the start of treatment a set of physical disciplines that reduce the likelihood that they remain force-free right from the start. So they are already reporting using physical force, physical discipline from the beginning of the study. You can see that the percentage of cases that remain force-free drops, and it drops precipitously, and then it kind of levels out. So it already is telling us that parents, caregivers, not only are using, but they're telling us they're using force from the start of treatment. What you also see is that the CBT, which is the top row, shows less force because it has a higher probability of cases that have not used force, they are force-free, than the proportion of force-free cases that receive the family therapy. So what's interesting there is that there is a slight benefit in reducing the use of force in the CBT content of AFCBT compared to the family therapy content. But they both do have some percentage of cases that remain force-free. Now this is the child report, and you can see it's a similar pattern but a little different in that the proportion of cases that remain force-free based on children's reports is actually higher than the proportion of parents reporting being force-free within the CBT condition. The rates reported by the children in the family therapy, as you see here, are very similar to the rates reported by the parents in the family therapy. But the pattern is similar. There's an initial drop in the proportion of cases that remain force-free, and then it continues to drop a little bit, and then it begins to level out. Again, highlighting the fact that we need to ask about these things if we're going to learn what's happening, because our intervention targets this. And what we've now learned is they will tell us this, they do it, and then eventually, hopefully, a larger proportion of families will not use it. So this is from a study, the one I mentioned that was published in 2011. And what's interesting about this study is that it's not a controlled trial, it's a trial of routine cases who happen to receive services, and they could have received various services that included AFCBT. What I think is interesting about the study is we collected information about all of the 4 interventions being delivered in that agency. And so what we were able to do is statistically control for the use of the other three treatments, TFCBT, PCIT, and CPP, and ask this question. Once you control for the effects of those three other evidence-based treatments, is there a relationship between the amount of unique AFCBT content for that particular case and that case's outcome several months later? And the answer is yes. Because what you see here is we've now run analyses to look at, the correlation, in a sense, between the type of AFCBT content that was used, that was unique to AFCBT, and the child's outcome. And what you see is, if you look at the general content, the first row, or the first column, what you see is that general AFCBT content, like general problem-solving skills, general communication skills, most of the correlations are not necessarily significant. And what you see here are the significance levels, and for them to be significant, they need to be at 0.05 or lower. So there's only one that comes close, and that's anger. So there's a almost significant relationship between the use of general content and reductions in the child's self-reported anger. But the correlations and the p-values, the significance values shown here that are highlighted in bold, show that there are several improvements in those outcomes as more AFCBT abuse-specific content is used. And what I mean by abuse-specific is, this is the content that focuses on a given interaction that was actually abusive or that involved physical force, like a clarification, or, for example, doing psychoeducation around the role of force. Those obviously are topics you only go into, you make them relevant to a particular incident of physical force or physical abuse. And what you see is that to the extent that the clinician uses more abuse-specific content from AFCBT, there's a significant reduction in the child's externalizing behavior, anxiety, anger. There's improvement in the child's social competence, and there's an improvement in the parent's own use of aversive communication. They're less likely to use this harsh communication to the extent that abuse-specific content from AFCBT is used. So that's comforting for us. It at least shows that even when you control for these other three interventions, there's a significant improvement to the extent you use more unique content in AFCBT. Now this too shows data from the same study. The interesting thing about this is that these are now not standardized self-report scales. These are ratings from the clinician, the parent, or both together. And what you see is if you average the clinicians or the therapist's ratings and the parents' ratings, you see that to the extent that that clinician uses more abuse-specific content, they both rate the child as less scared and more happy, as more safe. The clinicians rate those children as being better able to have friends and without hurting them, and of course respecting their bodies and their privates, which is also part of that item. And they say that there's a better prognosis for those children. In addition, the parents' reports indicate that to the extent that more of that content was used, they are saying that their kids also are better able to have friends and be respectful, and that they are more likely to treat them fairly and well, and also not touch their private parts. So those are the items on this scale that get at respecting others' bodies and others' peers. And what you see is that parents and therapists, both separately and when aggregated together, report improvements to the extent that this unique abuse-specific content was used. Again, I think supportive of the other data that we've just talked about. Now, I want to mention a study that's fairly recent, published in 2012, and this was a study that first examined community implementation of AFCBT. And in this case, what happened was providers in 10 agencies were randomized to either receive AFCBT training or they received whatever routine training occurred in their agency. And so the purpose of the study was to ask the question, if
providers in everyday activities which are quite diverse, different from one another, if they receive AFCBT training, do they learn more about AFCBT? Are they more likely to say they are using the skills of AFCBT? I mean, after all, if we're disseminating AFCBT to everyday clinicians and they don't learn from our training, well, they're not likely to benefit their families. So the first question is, do they pick up the skills? Are they more likely to use AFCBT after training? And are they more likely to use it after training has ended, many months later, like a year or so? And so in this study, what you see at the bottom is that, some of the individuals who received AFCBT training, there were about 90 of them, about almost 90% of them participated in at least one training activity, and 68%, in other words, 2/3, met a training completion definition whereby they had to complete 7 of the 10 consultation visits, and they had to participate in all 3 days of our workshop training. And so in terms of the outcomes, those practitioners who actually received any AFCBT training were more likely to improve on an AFCBT knowledge scale. They were more likely to report using the teaching processes in AFCBT. Those include things like setting an agenda, doing a role play, providing feedback, assigning home practice. They were also more likely to use what I referred to earlier as the abuse-specific skills with those families, and they were more likely to use the general content skills in AFCBT. So essentially, those trained in AFCBT do report, not just over a short interval, but over a longer interval, like through a year, higher levels of all of these skills and a higher level of AFCBT-related knowledge. This isn't necessarily that surprising on the one hand, but it is good to know, and it's important for us to realize that when we do train, there is a significant improvement in the skills, the competencies of the trainees. So with that, I want to just offer some information about clearinghouses and websites where AFCBT can be found, and then I'll just show you some references. And I suppose what I should say first at this point is that, these clearinghouses are very different from one another. They're important for our field. They provide, in many cases, outside feedback and critiques about every aspect of an intervention, including its implementation, its content, its research, its cost. And so I suggest that if you have time, you take a look at some of these to see what others say about AFCBT, and I've given you the addresses so you could easily find them. I also want to mention that we could probably never have enough research to feel comfortable with the level of support for AFCBT and for our knowledge about how it works in the real world. We know we have some studies, and we know, fortunately, we have some supportive outcomes, but clearly we need more studies. They are being done now. And also, we need to be able to reach far more people than we do now. So hopefully, this kind of information will support efforts to disseminate AFCBT to community practitioners. And as I mentioned, so here are some references so that you can look up the specific studies that I'm referring to here and see for yourself whether, first of all, you agree with my characterization of the outcomes. Also, you can read more about the methods, the sample sizes, the content, the time intervals, all of the measures that people are interested in, and other caveats and issues that come up in the course of a study. I think it's a great idea if someone can read some of the papers, especially some of the more recent ones, to get a better understanding of the literature and evidence based on AFCBT that's current. My hope is that at some point we'll have more data and more studies to talk about. We have one, as I mentioned, we are writing up now, and it does look like it has supportive outcomes in terms of improving children's functioning, in terms of reducing the likelihood that caregivers use harsh discipline. But that study has not been published, and at some point, hopefully, it will be, and we'll be able to talk about it. So with that, I want to thank you for your attention, And happy reading.